Good evening, Supreet sir.
Hi, good
Tina ma'am?
evening.
Yes, sir. Ma'am?
Shall we start?
Yes, ma'am. Good evening, everyone. On behalf of the International Association for Integrated Oncology, I extend a very warm welcome to all our respected faculty members and participants joining us today. I'm Rukmini and I'll be your compare for this evening's scientific deliberations. Today's session focuses on rapidly evolving and clinically significant area, HER2 positive breast cancer, a evolving landscape. To begin the evening proceedings, it is now my privilege to introduce our program director, Dr. Tina Rajan, a consultant medical oncologist from NS Memorial Institute of Medical Sciences, Kerala. Dr. Rajan is a seasoned medical oncologist with extensive experience in breast cancer management and academic oncology leadership. She has been instrumental in driving clinical excellence and contributing to oncology education across multiple platforms. We are delighted to have her leadership for today's program. I now invite Dr. Tina the introduction and contact setting. Ma'am, over to you.
Thank you for that kind words. So, I'm Dr. Tina Rajan, and it's my privilege today to serve as program director for tonight's session and welcome all of you, all our eminent speakers and all delegates to this session. So today we'll be dealing with HER2 positive breast cancer, the evolving landscape, right from the neoadjuvant therapy going to the adjuvant therapy and management of multiple lines of metastatic disease. We have an esteemed panel members with us today. They are eminent young dynamic medical oncologists, Dr. Supreet, Dr. Anbarasan, Dr. Nihanti, and Dr. Shruti. I welcome you all. And without wasting much time, we'll move on to the first speaker, Dr. Arun Supreet. So he'll be talking on the neoadjuvant and adjuvant HER2 positive early breast cancer. Over to you, Supreet.
Thank you, Dr. Tina and IAIO for inviting me to deliver this talk. It's a pleasure always to take part in IAIO lectures. Let me share my screen and good evening to the attendees as well. Before I share my screen, I would like to tell the participants or attendees that you guys can feel free to put in your questions in the chat box so that we can address them at the end or probably whenever it is possible. Okay. Hope you guys are able to see my screen.
Yes, sir. Perfect.
Yeah, so let us start with the management of early stage HER2 positive breast cancer. We all know how far we have come in the management of early stage when it comes to HER2 positive disease with the advent of a lot of monoclonal antibodies, antibody drug conjugates, and TKIs that have been coming up every year. There has been a new molecule that is getting approved in the advanced stage, and then it is gradually getting its role in early stage disease as well. So if you see the evolution, we are not going back into the era of only chemotherapy. We will be focusing on the trials which established anti-HER2 therapy along with chemotherapy as the standard of care. If you see, 2006 was the landmark year where trastuzumab was approved based on NSABP B31, NCCTG trial, HERA, and BCRG 006, all of which have established the role of trastuzumab in adjuvant setting along with chemotherapy for a period of 1 year. And then came the role of neoadjuvant chemotherapy and neoadjuvant dual anti-HER2 therapy, which remains the standard of care even today by and large in India. And it is based out of two phase 2 trials, Neosphere and Trifina, which was approved in the year 2013. Then a whole lot of adjuvant escalation trials came into picture. The first one was neratinib, which kind of showed mixed results. Then it was Affinity, which established PER2 TRAS2, and then escalation to TDM1 and TDXT is where we are standing today. Let us look at some of these trials partly in detail and some of those trials very briefly. We all know how various anti-HER2 therapies act, but just to cover briefly, trastuzumab, pertuzumab, margetuximab, zanidatamab, all these are various monoclonal antibodies, and we know that they bind to the extracellular domain at various sites to block the HER2 signaling and thereby inhibiting the downstream signaling activation. And this blockade happens by inhibiting homodimerization or heterodimerization of HER2. We all know that HER2 doesn't have any specific ligand. It is the HER2's the dimerization of HER2 with HER2 itself or with other HER receptors that leads to downstream signaling activation, and that is inhibited by antibodies. Then you have TKIs, which bind to the intracellular tyrosine kinase domain and inhibit the downstream signaling pathway. Then comes the ADC, which is having a cytotoxic payload. It binds to the receptor, gets internalized and gets released in the cytosol, goes into the DNA and causes cytotoxicity. Some of these ADCs get diffused outside into the extracellular space from the intracellular space, causing bystander effect by inflicting the cytotoxic damage on the adjacent cells as well. So it essentially it's not essential that adjacent cells also show HER2 expression. By means of bystander effect, these ADCs can cause cytotoxicity. Now, let me deal with my talk in a different manner. It is our usual pattern wherein we see the evolution of trials, discuss some guidelines, and then finish off with our own interpretation of the trials. But I thought I would split this into 7 chapters very briefly, depending on how anti-HER2 therapy has been evolving over a period of time in each setting. In the first setting, as I have already discussed, it is in the adjuvant where trastuzumab was established as the standard of care based on NSABP B31, which is a landmark trial. And then HERA or BCIRG 006, all these trials use trastuzumab for a period of 1 year and have uniformly demonstrated significant overall survival benefit. And the indication for adjuvant trastuzumab today, as of today, remains patients with PT1B or PT1C disease onwards, and anybody with node positive disease. So this is how the anti-HER2 therapy came into picture in curative setting for the first time. Then you have a bunch of anti-HER2 escalation trials. So the previous list of trials were anti-HER2 escalation, which worked. And these are the list of trials which escalated beyond trastuzumab, of which a couple of trials worked partially and a couple of trials were blockbusters. The first two, if you see, Extenet and Affinity. Extenet basically randomized patients after completion of 1 year of adjuvant trastuzumab, and patients were given additional 1 year of neratinib. And this particular trial did not meet its primary endpoint of overall survival. You can see the curves are bang on top of each other, but there was a selective, very selective subset of patients, especially those with HR positive disease as well, and who had residual disease after completion of neoadjuvant therapy, had some benefit in terms of overall survival as well as disease-free survival. What do the guidelines say? The adjuvant neratinib can be considered in patients who have received adjuvant trastuzumab, but it is a trade-off with the meager survival benefit or a questionable survival benefit, because we need to remember that it was only a subgroup analysis that showed overall survival benefit. And the trade-off is with the significant GI toxicities, especially dry area. And also, we don't know its role today, where escalation to TDM1 and also escalation to TDXT is the standard of care, regardless of the HR status in patients with residual disease. So even ESMO doesn't include neratinib as a treatment option in its guideline. Affinity, if you see, initially for 5 years, the overall survival benefit was not seen. From 7th year onwards, we started seeing some separation of curves. Affinity basically used pertuzumab, trastuzumab as the adjuvant anti-HER2 therapy regimen after completion of, along with chemotherapy and after completion for a total period of 1 year. And we can see that the absolute survival benefit at 10 years was 1.8%, which is very small, but still it was statistically significant. But if you see patients with node positive disease and with hormone receptor positive disease, there was statistically significant benefit. If at all a patient has undergone on upfront resection and is presenting to us with node positive disease or hormone receptor positive disease, probably we can consider affinity as the treatment approach to that particular patient. But of late, even the surgical oncology colleagues have been gracious enough to send patients before doing the surgery for neoadjuvant therapy. So this trial probably might not hold its relevance going ahead increasingly. If you see the other two trials, KATHERINE and TDXT, KATHERINE even today remains the standard of care in patients who had residual disease after receiving neoadjuvant chemotherapy with dual or single anti-HER2 therapy. And it has shown statistically significant benefit. Even at 7 years, there was about a 5% absolute overall survival benefit. And we should remember that majority of the patients in KATHERINE trial received single anti-HER2 therapy in neoadjuvant setting. While in DESTINY Breast 05, a majority of the patients received dual anti-HER2 therapy because by the time DB05 started recruiting, dual anti-HER2 therapy got established very well as the standard of care. Though by the time KATHERINE was also recruiting, the dual anti-HER2 therapy in neoadjuvant setting was the standard of care. But DB05 was a more robustly designed trial. And DB05 actually selected the population very carefully. It selected only those who had inoperable disease to begin with. They received neoadjuvant chemotherapy plus dual anti-HER2 therapy. And then they should have had residual disease, or patients who had residual nodal disease after completion of neoadjuvant chemotherapy plus anti-HER2 therapy. And later on in the adjuvant setting, they were given 14 cycles of TDXT, which showed statistically significant IDFS benefit. OS data is still immature, but going by the way TDXT has established itself in palliative setting, we all know it is a no-brainer where this trial is headed. Then there were a bunch of anti-HER2 adjuvant escalation trials which failed completely. So it includes HERA, which studied 2 years of trastuzumab versus 1 year, and it clearly showed there was no DFS benefit or OS benefit. ALTO was lapatinib concurrently or sequentially after completion of 1 year trastuzumab, and again it was a failed trial. And TDM1 plus pertuzumab was another trial wherein patients should have received neoadjuvant therapy, and those and with residual disease would go on to receive TDM1 plus pertuzumab, and there was no OS advantage. TEACH was another trial where trastuzumab was replaced with lapatinib. Trastuzumab was not used at all. Only lapatinib was used, and it did not show any OS benefit. So all these approaches were negative. All these approaches were failed approaches, and therefore these are not in clinical practice currently. Then comes the chapter 2, which is adjuvant anti-HER2 de-escalation. So these are the various trials which looked at the duration of anti-HER2 therapy in the adjuvant setting, of which the most discussed two trials are Persephone and FAIR. Persephone was conducted in UK and FAIR was in France. Both these trials looked at non-inferiority of 6 months of trastuzumab with 1 year of trastuzumab, and showed different results. And this difference happened because of different non-inferiority margins. Persephone accepted a non-inferiority margin of 1.33. And the absolute loss of DFS at 4 years that was accepted by Persephone was 3%, while it was just 2%, and non-inferiority margin was 1.15. And if you can see, Persephone trial, the OS of Persephone trial, upper limit of the confidence interval had crossed the non-inferiority margin. Therefore, it was a negative trial, but FAIR showed since it had a much more liberal non-inferiority margin, it showed, sorry, I'm saying the other way around. It is the Persephone which was positive and FAIR which was negative, and Persephone had a much more liberal non-inferiority margin, and therefore it came out to be a positive trial. These two trials were basically used in the COVID times, where patients used to find it difficult to get admitted for 1 year of trastuzumab, and therefore 6 months of trastuzumab was offered to these patients, or it found its use more in the era where trastuzumab didn't have generics, and even if generics were available, they were pretty expensive. But these trials do not hold true for today's practice anymore. There is another ad trial which is okay. This is about anti-HER2 de-escalation in adjuvant setting. Then next chapter is about adjuvant chemotherapy de-escalation. We have 3 main trials. APT, all 3 are phase 2, of which APT trial is the most popular one and most widely accepted. It basically included patients with stage 1 HER2 positive disease and node negative HER2 positive node negative disease, and the patients received 12 weeks of paclitaxel with trastuzumab for a total of 1 year. And it showed that at the end of 10 years, IDFS was about 91.3% and OS was 94.3%. And this has been a practice-changing phase 2 trial when it comes to adjuvant de-escalation. But we need to be careful while choosing the population for APT regimen. Only those with the PT1B or PT1C disease would be ideal to be treated with APT approach, because very few T2 disease patients, around 9% of the patients were included in the trial, which means anybody with tumor size more than 2 centimeters, we should be very cautious while extrapolating the results from this trial and implementing in those patients. But otherwise, in patients with very early stage node negative disease, APT trial should be the standard of care as of today. Then came ATTEMPT and RESPECT trial. So ATTEMPT is a trial which compared taxane with trastuzumab versus TDM1 alone, and it showed that there was no OS advantage with TDM1 replacing trastuzumab plus paclitaxel. But if some patient is wanting or preferring a chemotherapy-free regimen, this is something that can be offered, because we can see that the IDFS and OS were not different between the 2 arms. Then came the RESPECT trial, which specifically took frail elderly patients. We all know frail elderly patients a lot of times may not be either fit for chemotherapy because of their poor comprehensive geriatric assessment or geriatric screening, or because of multiple comorbidities, or patients by themselves may not be willing to take chemotherapy. In such situations, whether trastuzumab monotherapy is as good as trastuzumab plus chemotherapy was the question in the trial, and it was found that trastuzumab monotherapy was inferior in terms of DFS. But if you look at this was the Kaplan-Meier curve, and if you look at the hazard ratio, it was the upper limit of the confidence interval. It was crossing the non-inferiority margin, and if you see the restricted mean survival time, which means the average number of patients who are progressing at a particular time point, which was at 3 years, the mean DFS loss was less than 1 month. So in a patient who is very frail, who doesn't want chemotherapy at all, but is fitting into the criteria of T1B, T1C disease, in such situations, you can discuss the scale of loss or mean survival time that is lost by the patient and offer single agent trastuzumab. This actually I have put to just to show how negative trials can also lead to newer therapeutic approaches. HER2-DX, PCR, and HER2-DX is the upcoming molecular scoring genomic risk stratification system in HER2 positive breast cancer as well in the lines of Oncotype DX, which is used in HR positive disease. And it was found that in patients who had HER2 DX low intermediate score, if they receive only trastuzumab, as compared to trastuzumab plus chemotherapy, they had non-inferior overall survival and recurrence-free survival. This probably shows that there are a certain select set of patients. If they are selected based on molecular risk stratification, probably we can do away with adjuvant chemotherapy and just offer 1 year of trastuzumab. Then the chapter 4 is concept of neoadjuvant therapy. The OG neoadjuvant trial was NSABP B18, which gave anthracycline plus taxane neoadjuvantly. And it showed basically that patients who achieved pathological complete response had better overall survival and DFS as compared to those who did not achieve pathological complete response at 9 years. This is so this trial also showed that there was no overall survival or disease-free survival difference between neoadjuvant approach versus adjuvant approach. But neoadjuvant approach gave us prognostic information, and also patients who achieved pathological complete response probably can de-escalate their adjuvant phase of treatment, or those who did not achieve pathological complete response probably can escalate their adjuvant. So this trial essentially established today's practice, the foundation to today's practice that we are doing in HER2 positive breast cancer or even in triple negative breast cancer, because we should remember that B18 and even B27, which was another trial which looked at anthracycline neoadjuvantly versus adjuvant chemotherapy and showed that there was no OS difference and DFS difference as well. But in patients who receive anthracycline plus cyclophosphamide, after 4 cycles, if they continued to be partial responders and they went on to receive taxane, they were compared to those who received just preoperative AC followed by surgery followed by taxane. It was found that those who responded to chemotherapy had higher chance of achieving pathological complete response rates as compared to those who did not respond to anthracyclines. And if you are completing the taxane in neoadjuvant setting itself, you are able to achieve higher chances of, you are able to achieve pathological complete response rates in higher proportions as compared to those who received taxane adjuvantly and anthracycline neoadjuvantly. And this is translating into disease-free survival, where you can see that those who achieved PAT-CR had better DFS and OS as compared to those who did not achieve PAT-CR. So these 2 trials, they were unselected for molecular subtypes of breast cancer. All patients were included, HR positive, triple negative, and HER2 positive, and it was found that patients had pathological complete response is a good surrogate for survival. The 5th chapter is about neoadjuvant anti-HER2 therapy escalation. So we have all discussed so far about adjuvant anti-HER2 therapy escalation or chemotherapy escalation. Now, neoadjuvant anti-HER2 therapy escalation was established first with the NOVA trial, wherein patients received perioperative trastuzumab, which means in neoadjuvant setting concurrently with chemotherapy followed by surgery, and then adjuvant trastuzumab alone versus chemotherapy alone. We need to remember that this trial in the control arm did not have any anti-HER2 therapy, but still it showed that patients had 3-year EFS benefit, and more importantly, pathological complete response rates improved. Now, in the previous trials, we have seen that pathological complete response rates led to better DFS and OS. And here we are seeing that adding anti-HER2 therapy leads to better pathological complete response rates and thereby indirectly resulting in better EFS. Then, based on this concept, came NeoSphere trial, which basically added taxane to dual anti-HER2 therapy versus single anti-HER2 therapy, and it showed that patients who received dual anti-HER2 therapy had better OS, and this remains the standard of care today. But we should also bear in our mind that in this trial, patients received trastuzumab along with anthracycline, which is not the standard of care today, that I would be discussing in the next slide. And there was another trial called TRIFINA, which again was aimed at looking into the cardiac safety of adding pertuzumab to the trastuzumab, but the secondary outcomes were pathological complete response rates and DFS, and it was found that patients who received dual anti-HER2 therapy along with anthracycline-based chemo or TCH found a better PCR and DFS and OS. Based on these two trials, we are currently practicing dual anti-HER2 therapy in the neoadjuvant setting as the standard of care. Coming to the question of giving anti-HER2 therapy along with anthracycline. So this was a trial, ACOSOG Z1041, which basically compared FEC 4 cycles followed by paclitaxel plus trastuzumab for 4 cycles, followed by surgery, versus paclitaxel plus trastuzumab followed by FEC plus trastuzumab. So we need to see the difference between the two arms, wherein trastuzumab was given concurrently with FEC in arm 2, and the outcomes, survival outcomes were not different. Based on this, we know that anti-HER2 therapy given concurrently with anthracyclines is not giving us any additional advantage, but coming at the risk of higher cardiotoxicity. There was another trial as well, but I'm not going into that discussion. If you look at this slide, basically Trifina regimen is what we are following today as the standard of care. In this, there were 3 arms. Again, the same point, TCHP in the one arm versus FEC followed by THP, and FEC HP followed by THP. All these 3 showed same overall survival and similar pathological complete response rates. Therefore, you can safely omit anti-HER2 therapy concurrently with anthracycline if your neoadjuvant chemo of choice is anthracycline. But if you're offering TCHP, you offer 6 cycles and then send the patient for surgery. Neosphere basically just added anti-HER2 therapy to single agent taxane, and still you can see that there was no difference. There was significant difference between a dual anti-HER2 versus single anti-HER2. But there was another arm which included only HP, which means there was no chemotherapy in this, and it still showed a pathological complete response rate of 17% and DFS of 80%. This is interesting, and this led to further chemo-free regimen approaches, which I would be discussing subsequently. Then coming to neoadjuvant chemotherapy escalation. There were a couple of trials which again included unselected breast cancer patients, JAPAR Quattro and JAPAR Sixto. Basically, one trial added capecitabine to neoadjuvant chemotherapy, and the other added carboplatin to neoadjuvant chemotherapy, along with trastuzumab, lipodox, lapatinib. So none of these, neither of these trials showed statistically significant benefit. Therefore, it is established that you can escalate anti-HER2 therapy in neoadjuvant setting, but escalating chemotherapy in neoadjuvant setting is not giving any benefit to us. Then comes chemotherapy de-escalation in neoadjuvant setting. We have a whole bunch of trials. BCIRG is an adjuvant trial, but I have included here because this trial established that anthracycline-free regimen is non-inferior or numerically it is superior to anthracycline. Though statistically there is no difference between the two approaches, but you are avoiding the risk of cardiotoxicity and secondary AML and stuff like that, especially when you are expecting anti-HER2, expecting HER2 positive patients to survive for a prolonged period of time. This trial actually established anthracycline-free regimen as the standard of care. Then came the TRAIN-2 trial, which basically attempted this in neoadjuvant setting. It offered weekly paclitaxel carboplatin plus trastuzumab versus anthracycline plus HP regimen, and it showed that pathological complete response rates, EFS and OS, were no different between the two arms. And this sort of established TCHP as the standard of care in neoadjuvant setting, apart from anthracycline plus HP. Then there are other trials which came recently last year, Helen 006 and Neocar HP, both looked into omitting carboplatin in neoadjuvant setting, just offer taxane plus HP, and the comparison with taxane carbo plus HP showed that there was no there was no difference in pathological complete response rates. Even EFS rates were no different. This shows that patients, if they are selected carefully, can omit neoadjuvant carboplatin as well, and we can just offer them taxane plus dual anti-HER2 therapy. So again, is something that I would be discussing in the next chapter, which is response adaptive escalation de-escalation strategy. Daphne trial. This is an interesting phase 2 trial wherein patients were given 12 weeks of taxane plus prostupertu, and then patients would undergo surgery. And based on pathological complete response rate, if the patient achieved PAT-CR, they would just be on surveillance without any adjuvant therapy. And if the patients did not achieve PAT-CR, they would receive adjuvant systemic therapy, which can include chemotherapy, plus or minus anti-HER2 therapy, which can be DDM1 as well. And this showed that if you are doing risk-adapted approach, you can still achieve 5-year overall survival rate of 99% and 5-year distant recurrence-free survival rate of 100%, which goes on to say that if you are choosing your patients wisely and carefully, you are not only achieving pathological complete response rates in about 56% of the patients, with a de-escalated neoadjuvant chemotherapy regimen, but also sparing about 50%, those 56.7% of the patients from the toxicity of escalated chemotherapeutic regimens in the neoadjuvant setting. There is a ctDNA analysis which was recently presented, and it showed that neoadjuvant THP itself has resulted in ctDNA clearance in about 96% of the patients. And additional patients had the ctDNA clearance post-surgery, but its impact on survival is yet to be published. Then came the Fergain-1 trial. So this again is another smart approach based on imaging. You offer, in this trial, patients in one arm were offered TCHP, which is the standard of care, for 2 cycles. And in the other arm, patients just received PH without any chemotherapy. And if the patient had HR positive disease as well, they received endocrine therapy for 2 cycles. And then patients underwent PET-CT. If there was response, at least 40% reduction in the tumor size, they were considered to be responders, and they just continued PH plus or minus endocrine therapy alone for 6 more cycles. If they had no response, they would receive TCHP for 6 cycles, which is the standard of care, and then undergo surgery. And then if the patient had achieved pathological complete response, they would complete maintenance PH plus endocrine therapy. And if they have not achieved pathological complete response rate, they would receive in the adjuvant setting 6 cycles of TCHP and complete 4 doses of PH alone. And the outcomes, if you see, if you are doing this risk-adapted approach in all comers, the IDFS rate is about 95.4%. But more importantly, you are sparing a large number of patients by doing this risk-adapted approach from the toxicities of neoadjuvant chemotherapy or even adjuvant chemotherapy, as a matter of fact. Fergain-2 is another imaging-based risk-adapted approach. You can see patients receive 8 cycles of HP plus or minus ET, and they undergo MRI, and then they undergo surgery. If the patients have achieved pathological complete response rate without any question of chemotherapy, they just complete anti-HER2 therapy plus or minus hormone therapy. If they have microscopic residual disease in the nodes or molecular positive disease, they would go on to receive TDM1 for 10 cycles. And if they have nodal residual disease, again, they would receive TDM1 for 10 cycles, and then they would be on. But we should note that only patients with HER2 3+ status, not those with HER2 2+ FISH positive status, were included in this trial. And it showed that pathological complete response rates with just HP, as I was discussing earlier in Neosphere trial, in one of the arms, patients did not receive taxane, only HP was given, and 16% PAT-CR rates were found in that particular trial. And in this trial, we are seeing 59.6% pathological complete response rates with just HP without any chemotherapy in the neoadjuvant setting. Further trial analysis are awaited. This was presented in ESMO Breast this year. This is kind of confusing trial, but I'll try to simplify it as much as possible. This is basically looking at a completely ADC-based neoadjuvant and adjuvant therapy, wherein TDXT is given to patients for 12 weeks in the neoadjuvant, which was compared to the standard TCHP or the weekly taxane carboplatin plus dual anti-HER2 therapy, and then the patient would undergo surgery. If the patient did not achieve pathological complete response rate, they would go on to receive further chemotherapy plus anti-HER2 therapy as per physician's discretion. If the patient has achieved pathological complete response rate, after just 4 doses of TDXT, you are basically giving the patient adjuvant trastuzumab plus or minus pertuzumab. In the other arm, there was 18 weeks, which means 6 cycles of TDXT was compared to TCHP. And again, it was a similar approach was followed. And then the TDXT arms of both these cohorts were then sent for surgery, and if they have not achieved pathological complete response rate, they would go on to complete chemotherapy plus anti-HER2 therapy. This basically is trying to do away with chemotherapy and just rely on 4 to 6 doses of TDXT and see how many patients would achieve pathological complete response rates, whether we can completely omit chemotherapy in these patients, both in neoadjuvant and in the adjuvant setting. The results are awaited. The trial is, I think, recruitment is closed, and we will soon see the analysis. To conclude, every trial, be it positive or negative, has its own application. Positive trial establishes a new standard of care or an additional option. Negative trial establishes a new hypothesis or a new lesson from which we can derive another trial design. Understanding the evolution of treatment always teaches us what not to do more than what to do. This is just a smart analogy to say that earlier we used to hit every patient with chemotherapy. But later on came the era of treating very few patients with chemotherapy, risk-adapted approach, and we are going towards the future of completely chemotherapy-free regimens in HER2 positive breast cancer, especially. With this, I conclude my talk, and I thank the organizers for giving me this opportunity.
Thank you, sir, for those insightful overview. Moving ahead, it is a privilege to introduce Dr. Anwar Hasan Shekhar, a consultant medical oncologist from Tata Medical Center, Mumbai. We look forward to his talk on first-line metastatic HER2 positive breast cancer. Sir, the floor is yours.
Good evening, everyone. I would like to thank organizers and Dr. Tina ma'am for giving me this opportunity. I hope my screen is visible.
Yes, sir.
Yeah.
But
let's go on to today's presentation. Dr. Supreet excellently described regarding the role of non-metastatic breast cancer HER2 positive setting. Let's take a quick review in management of metastatic advanced breast cancer. We have n number of drugs approved in metastatic breast cancer setting, especially in HER2 positive disease. Most of them are available in India, few of them yet to come to India, and many of them are in pipeline. Let's discuss a case based on which we discuss subsequent treatment management in first-line setting in HER2 positive breast cancer. This is one of the patient recently presented in our hospital, 15-year-old female, premenopausal woman with no comorbidities and no family history, evaluated for abdomen pain, back pain, and breast lesion. This patient, on a further evaluation, PET scan showed right breast cancer lesion, and also she had bilateral lung, liver, and bone metastasis. Subsequently, her biopsy was done from the right breast, which shown invasive breast carcinoma with ER/PR negativity and HER2 positive IHC 3+. So with this de novo metastatic HER2 positive breast cancer, ER/PR negative, and IHC of 3+, let's move on. What are the given options available in this scenario? Let's first discuss with the Cleopatra regimen, which is the one which occupied the treatment management in first-line HER2 positive breast cancer over a decade. This trial started enrollment from 2008 to 2010, enrolled close to 800 patients, and these patients has been randomized into 2 arms. The study arm contains combination of dual anti-HER2 therapy, pertuzumab along with trastuzumab, in addition chemotherapy. The chemotherapy here they utilized is docetaxel. In the control arm, chemotherapy backbone is same, but instead of dual anti-HER2 therapy, they utilized with single anti-HER2 therapy, that is trastuzumab. And here the primary endpoint is progression-free survival, and secondary endpoint includes overall survival. Key features to note down here is 10% of patients had prior trastuzumab in the adjuvant setting, and 50% of patients had de novo metastatic diseases. and endocrine therapy not allowed during maintenance in this regimen. Coming to the result, what is more impressive with the result is median progression-free survival of 18 months versus 12 months in this study, and the median overall survival also 57 versus 40 months, with an impressive delta of 16.3 months seen with the dual anti-HER2 therapy combination in this setting, which made the landmark PFS of at 8 as 16 versus 10 and landmark OS at 8 as 37 versus 23 months. And this made the regimen lasting beyond a decade in the management of first-line HER2 positive breast cancer. What are the key features to note down in long-term survivors in this study? With the years pass on, 6 years, 7 year and 8 year overall survival rate, there are a good number of patients who continues to maintain a response and survive beyond these years in the metastatic setting. Who are those long-term survivors? When we dig it out, those patients who had de novo metastatic breast cancer and those who had longer disease-free interval and non-visceral disease, these are the specific group of patients who had long-term survivorship with the usage of dual anti-HER2 therapy in this situation. They have also done some biomarker analysis where they seen that patients who had IHC3+ and high HER2 mRNA and low level of serum HER2 are the one showing long-term survival in this situation. Also, one another important marker is PIK3CA. Those who are having PIK3CA wild type tend to have longer progression-free survival in this situation. Any data available in Indian scenario? Even though decade-long trial, Indian scenario real-world data just now published in Indian context, close to 134 patients has been evaluated in the retrospective study design. Here, the primary chemotherapy backbone is docetaxel and done over a period of 8 years duration, which signifies that the higher cost for the dual anti-HER2 therapy. I think moving forward the situation, this scenario might change because of the availability of generic therapy at lower cost. What they found out here is median overall survival is 50 months, when Cleopatra it is 57 months and median progression-free survival is 30 months. Why is the difference between the real-world study and the standard study? It is higher amount of PFS, whereas OS is much lower, probably because of the usage of endocrine therapy in the maintenance setting. And here overall response rate is close to 70%, which is as similar as that. What is most pleasing here is the adverse event profile. Adverse event profile is much lesser in the real world scenario also. Another important question always arises here is in the Cleopatra, the standard backbone is docetaxel, whereas we often tend to use other taxane, that is nab-paclitaxel or paclitaxel in this situation. In fact, in Tata, paclitaxel is the most preferred regimen in this situation. What is the data to justify the usage of paclitaxel instead of docetaxel in this situation? There is a very well conducted phase 3 multicentric single arm study, which is called as per-use study design, which has recently published its long-term survival data also. This study primary endpoint is safety features and total 1,466 patients has been enrolled into the study design. They have used taxane as per the physician choice. So the physician has decided which kind of taxane used for the suitable patient. Accordingly, they choose the taxane. And the preferred taxane regimen is docetaxel in 54% of patients, paclitaxel in 41% of patients, and nab-paclitaxel in 5% of patients. And it has a median follow-up data of 68.7 months. What we are able to see here is all the three curves where they used chemotherapy backbone either with paclitaxel, docetaxel, or nab-paclitaxel hugging each other for progression-free survival. This indicates that taxane chemotherapy backbone doesn't make major impact when it comes to combination with dual anti-HER2 therapy. Coming to the primary endpoint, that is safety analysis, 60% of patients presented with grade 3 adverse event and probably 20% were related to pertuzumab related, taxane related by 17%, and trastuzumab related 17%, and taxane related by 36%. And is there any difference in terms of safety profile with regarding to chemotherapy? When it comes to docetaxel, there were higher incidence of grade 3 neutropenia and febrile neutropenia. And when it comes to diarrhea, all the three taxanes behave similarly. So when you are considering for docetaxel, try to consider an younger, fitter patient, and paclitaxel you can consider for an older patient in this situation. And this trial indicated 4 important parameters in this real world scenario. One, paclitaxel is a valid alternative to docetaxel in first-line metastatic HER2-positive breast cancer. Second important thing is usage of endocrine therapy as a maintenance part of treatment in this setting. Third important thing is median overall survival exceeding 5.5 years in these patients, which is again reassuring factor that in the real-world scenario also, the drug of dual anti-HER2 combination along with chemotherapy remain successful journey in the management of HER2-positive breast cancer. 2 important risk factors which proved that having high risk for this patient. One is prior usage of trastuzumab in this setting, and those patients who are having visceral disease, carries worse prognosis compared to other cohort of patient in this situation. So we have seen that the usage of dual anti-HER2 therapy in the first line setting. We have seen what kind of chemotherapy backbone we can consider. Next, what is there in the future? We have seen good number of patients who are having good amount of survival, but still, as per the Cleopatra regimen, as well as multiple other real world study scenario, what we tend to use is continuing anti-HER2 therapy for long period of time till the patient continue with progression. Those patients, they can get any benefit or relief by de-escalation of treatment. These are the two important studies, Phoenix study and HER2 NeoSTOP study, which is ongoing. It is a non-randomized study design. Primarily, they divide the patients after establishing long-term survivorship. Based on the patient willingness, they've been go for either observation or continuation of therapy. HER2 STOP is the one study which is about to get the primary analysis report. We can soon expect its result in SABC 2026. Coming to the next important aspect, what are the other potential approaches in management of in recent setting? Because over a period of decade, we had Cleopatra regimen, but in last 2-3 years, we have good number of approaches happening in the space of first line management of HER2 positive breast cancer. Right from the beginning, changing from the chemotherapy backbone to an ADC plus pertuzumab combination. Next important thing is optimizing the Cleopatra regimen by adding either CDK4/6 inhibitor or tucatinib in the maintenance strategy. Let's first start with the Destiny-09. Destiny-09 is a simple study. We all know that how good it is in terms of management of HER2 positive breast cancer in second line and third line setting. That's why it has moved quickly into the metastatic setting, as well as the trials published simultaneously for neoadjuvant and adjuvant setting, which is described by Suprit in the previous session. In the metastatic setting, they selected patients who are first-line HER2 positive breast cancer patient who had DFI more than 6 months from the last form of either adjuvant or neoadjuvant treatment. One prior line of endocrine therapy has been permitted for the study design. An asymptomatic brain metastasis patient has been selected for the enrollment. This patient has been randomized into 3 different arms. One arm contains standard regimen of dual anti-HER2 therapy along with chemotherapy, and 2 different study arms. One study arm contains TDXD along with pertuzumab, and another arm contains TDXD alone. Now we are going to see the results primarily for the arm which contain TDXD along with pertuzumab in comparison to chemotherapy. They have already informed that TDXD arm will be blinded and it will reveal at the time of final PFS analysis only. The primary endpoint in this study design is progression-free survival, and the key secondary endpoint include overall survival. Other secondary endpoints like overall response rate, duration of response, PFS2 also analyzed in the study design. Coming to the key findings in Destiny-09. Destiny-09 quite impressed everyone in terms of median progression-free survival, with TDXD plus pertuzumab arm shows median progression-free survival of 40.7 months versus 26 months in the chemotherapy alone arm, and 2-year progression-free survival of 70 versus 52 months. What is more impressive, even beyond 3 years, these patients tend to continue with progression-free with TDXD plus pertuzumab arm. Another important thing to note down here is even chemotherapy with dual anti-HER2 therapy arm, the median progression-free survival improved from 18 months to 26 months, probably because improving in the standard of care or usage of maintenance hormone therapy in this situation. Another important features to note down here is objective response rate 85 versus 78. But the key thing here is complete response rate. It is doubled, 8 versus 16% in the new study arm in this situation. And the median duration of response is also significantly higher in the study arm. What about safety profile? When it comes to safety profile, if we see overall grade 3 adverse event is seen in the both the study arm as well as control arm, and the serious adverse event also same situation. When it comes to special situations like interstitial lung disease, it is 12%, which is expected with the TDXD in the second line setting as well as third line setting. We see similar rate of ILD or pneumonitis in this situation. But we tend to more used to this kind of side effects. We effectively manage these side effects. We try to pick up in side effect in the much earlier setting also. Coming to the final conclusion part of Destiny-09, Destiny-09, which established as TDXD plus pertuzumab as a new first line of treatment option for HER2 positive advanced metastatic breast cancer patient. I would like to inform all the participants that it is not T-DXd alone in the first line setting. It is combination of T-DXd along with pertuzumab, which is showing improvement in the first line setting. So if you want to utilize first line setting with T-DXd, you should combine with pertuzumab in this situation. What are all the advantages of this combination? One is unprecedented median progression-free survival, which is exceeding beyond 3 years in this situation. Second important thing is it is showing higher objective response rate in this situation, and the PFS benefit improvement across all subgroup of population. And safety profile is manageable as we have ample amount of experience of using TDSD in the second line as well as beyond second line setting. Coming to the limitation with Destiny-09, the final overall survival is yet to mature. We need an additional follow-up data to further clarify regarding the long-term benefit of usage of this combination in the first line setting. Second important limitation is T-DXd alone also showing a very good advantage in the second line setting. We are not sure what is the benefit of T-DXd alone in the first line setting. There is a small bit of comparison between Cleopatra as well as Destiny-09. We see here the study population numbers are higher in the Destiny-09 because it is a 3-arm study design. Median age is similar in the both arm, and the amount of hormone receptor positive patients is higher in the Destiny-09 arm. Visceral disease wise, it is higher in the Cleopatra study. Coming to the significance with Cleopatra as well as Destiny-09, the Cleopatra has established long-standing first-line treatment in the management of HER2 positive breast cancer setting in the first-line scenario. Close to 47 patient had de novo disease in this situation. When it comes to Destiny-09, PFS, that is more than 3 years of median PFS in this situation. But one key important thing to note down is its key adverse event, that is ILD. In this situation, it is 12%. Like Cleopatra, we had a stop HER2 strategy. Anything similar strategy applicable for T-DXd also, because T-DXd now it is approved by FDA, US FDA also. When it comes to T-DXd as a de-escalation strategy, there is something called as D-method study, which is a phase 2 study design. Instead of going with T-DXd plus pertuzumab, here they utilize T-DXd alone induction in the first line setting for 6 cycles. After induction of 6 cycles, these patients will go on for maintenance strategy with Pertu and trastuzumab along with endocrine therapy if the patient is positive for hormone receptor, no endocrine therapy if the hormone receptor is negative. And this primary endpoint here is 1 year progression-free survival and 3 year overall survival. Let's wait for the result whether this kind of strategy will be helpful for this patient. Next important study, let's moving on here is PATINA study design. PATINA study design, we know that usage of palbociclib as a CDK4/6 inhibitor in the phase of maintenance setting. Key important feature right to note down here is not all patients with a HER2 positive breast cancer will be participating in the PATINA study design. Only those patients who are exhibiting either CR, PR or stable disease will be enrolled into the study, and these patients will be randomized between palbociclib versus no palbociclib. So technically, you cannot use those patients who are having progressive disease in this situation. It is an open label phase 3 randomized study design. Close to 518 patients has been enrolled into the study design. What are the key important features of this cohort is median age of this cohort is 53 years and most of them were postmenopausal women. Close to 30% of patients has received neoadjuvant anti-HER2 therapy in this situation. Even though the patients preferred primarily with either single agent HER2 therapy or dual anti-HER2 therapy, only 4% of patients enrolled in this study receiving single agent anti-HER2 therapy, which we are lacking currently in our Indian scenario. Hopefully, with the advent of lower cost dual HER2 therapy, probably we will also go towards this situation. And most of the patients enrolled in this study were IHC 3+ for HER2 receptor, 77%. When it comes to endocrine therapy, they keep it very simple. They used either aromatase inhibitor or fulvestrant. More than 90% of patients had AI in this situation. If the patient is premenopausal, they added OFS along with AI in this situation. And we have a median follow-up of close to 53 months for this study design. Let's break down with the side effect profile, because when we are adding maintenance treatment, we are adding extra amount of side effect for the patient for a long duration of treatment in this situation. When it comes to adverse event, we all know that palbociclib with addition, number of grade 3 adverse event going to increase. In fact, it is more than double, 80 versus 36%. What are the key side effects to note down in this situation? One is diarrhea. Grade 3 diarrhea incidence is 10%, grade 2 diarrhea is 30%. What is the time of onset of diarrhea? It is 2.3%. In fact, 30% of patients had baseline diarrhea at the time of starting for this study, probably because of the effect of pertuzumab in this situation. We all know that pertuzumab alone causes diarrhea. So combining with this kind of regimen might cause diarrhea in this situation. That is the reason for median onset of diarrhea at 2.3 months in this situation. What is more heartening is over a period of time, this diarrheal episode tends to come down further. What about dose reduction and dose discontinuation rate when we combine CDK4/6 inhibitor along with dual anti-HER2 therapy? Dose reduction rate is close to 60% and dose discontinuation rate is only 20% of population. Coming to the most important point, that is efficacy of the study design. They have given PFS at 1 year, 2 year and 4 years. At all the time point line, it is much better than the control arm. At 4-year point in time, close to 50% of patients continue to maintain response in the palbociclib arm. So 4-year PFS with the PATINA kind of strategy is close to 50% when we consider. Another important factor, they introduced a new terminology called as confirmed response rate. How it is different from the complete response? Confirmed response is nothing but those patients who exhibit 2 consecutive episodes of either CR or PR post introduction into the randomization into the study design. They are considered as confirmed response. What is the benefit? Those patients who are having confirmed response, their median duration of confirmed response is 45 months versus 30 months, which is much higher than the placebo arm with a delta of 15%. Coming to another important factor, CNS recurrence, because we all know that TKI, tucatinib, has a higher brain penetration, whether palbociclib also having similar effect in terms of controlling brain metastasis, especially those patients who enrolled into the study design at the baseline without any brain metastasis, whether it has any significance in controlling brain metastasis or not. PATINA again answered this study design at 3 different point in time, 1 year, 2 year and 3 year. At all the point in interval, it is much better compared to the control arm where only dual anti-HER2 therapy alone is used in the study design. So it is 13 versus 19% at the 3-year point in time, which is showing that palbociclib combination with anti-HER2 therapy also good enough to maintain CNS progression for those patients in this situation. What are all the concerns when it following PATINA kind of regimen? So first important thing is, can I consider for using single anti-HER2 therapy patient or patient who are having brain metastasis or men who are having triple negative breast cancer? So right now, the major challenge is single anti-HER2 therapy. Yes, because 5% of patient has been enrolled into the study design. Definitely, we can consider giving this benefit. But I wish more amount of patient will receive dual anti-HER2 therapy because that is the role, the maximum benefit is seen in this population. Next important question is how you are going to follow up this patient, because dual anti-therapy given every 3 weekly, whereas palbociclib is given every 4 weekly. Where you want to follow up the patient for blood testing, where you want to follow up for investigation. So I had this confusion. When in PATINA study, how they strategically followed is they did CBC in cycle 1 to cycle 4 every monthly interval, and then they switched CBC monitoring every 3 monthly. In the palbociclib arm alone, they did an additional CBC at day 22. So this is how you try to follow these patients who are enrolled in PATINA kind of regimen. Additional side effect, this is for resident. You should not tell only stop alone neutropenia as a side effect for PATINA kind of regimen. You should note down other important side effect when you consider combination of this regimen, because apart from neutropenia, these patients tend to have diarrhea, stomatitis, as well as fatigue. In first line metastatic HER2 hormone positive breast cancer, we use palbociclib for 23 months. Whereas here we are using close to 44 months because here the median progression-free survival is 44 months. So you need to note down that we are going to use longer amount of CDK4/6 inhibitor in this setting, triple positive setting. Another important question is what kind of endocrine therapy you would like to use in this patient. It must be either A or fulvestrant because it is the most preferred regimen in this PATINA study. If the patient is premenopausal, then you consider adding OFS for this patient. Is there any specific subgroup of patients get benefit by PATINA kind of regimen? The trial is quite underpowered to show this result. Another important question is the patient trial has not shown any OS benefit. Do I need to consider? Yes, you should consider because the median follow-up is close to 5 years and the median PFS is quite significant with the delta is close to 20 months in this situation. Another important study is HER2CLIMB-05. We all have confusion with respect to HER2CLIMB because we have 3 different HER2CLIMB. Unlike Destiny goes up to number 12. HER2CLIMB have only 3. HER2CLIMB in the multiple line progression where we combine tucatinib, whether it is showing benefit compared to capecitabine along with trastuzumab. Next important study is HER2CLIMB-02, where they try to combine tucatinib along with TDM1 in comparison to TDM1 alone. Third important study is HER2CLIMB-05, where they consider tucatinib as a maintenance strategy. Two important features to note down here is, this is the area where they try to introduce maintenance tucatinib in this situation. Among all the HER2CLIMB, this is the one showing promising future in this situation. Second important thing is, they have enrolled all the patient irrespective of hormonal status. That is, both hormone positive as well as hormone negative patient has been enrolled into the study design. So the key eligibility criteria is those patients who are diagnosed with HER2 positive metastatic breast cancer with good performance status, no asymptomatic brain metastasis, has been randomized between first line maintenance with tucatinib versus placebo in the study design. Like other trials, the primary endpoint here is progression-free survival, and the secondary endpoint include overall survival, progression-free survival, and CNS PFS in this situation. Coming to the baseline characteristics with the key finding, median age of the patient is 54 years, and visceral disease seen in 60% of population, with a good performance status of ECOG PSO0 is seen in 64% of population. They have enrolled higher percentage of population with de novo metastatic breast cancer, close to 70%, and IHC 3+ of 90%. So they try to include better prognostic population in this study design, and brain metastasis seen in 13% of population. And not to forget that hormone positive patient is seen in 52%. So this trial includes both hormone positive as well as hormone negative in this study design. Coming to the primary endpoint, that is progression-free survival, it is statistically significant. Median progression-free survival is 25 versus 16.3 with an hazard ratio of 0.76. When we take it up for hormone negative alone, the hazard ratio is getting better with the hazard ratio of 0.55. When it comes to hormone positive, it is 0.72. Although subgroup analysis only, it is not powered for the statistical significance. Next important factor we need to look into is CNS progression-free survival, especially for those patients who are having baseline brain metastasis. In these patients, definitely it is significant. There is doubling of median PFS is seen. In patients who are having control arm, it is only 4 months, whereas when we add tucatinib, it improves to 8.5 months. So coming to the summary of the HER2CLIMB-05 study design, it included hormone receptor positive patient also. All CNS comers, it has not shown any difference, but when the patient is having baseline CNS metastasis, there is doubling of PFS is seen. And this is the Kaplan-Meier curve, which is again demonstrating the benefit of addition of tucatinib for all comers, including hormone positive. Those patients who are having baseline brain metastasis, the median PFS is 24 versus 16, with a delta of 8 months is seen in this situation. Overall survival yet to mature, only 20% of event happened into the study design. Coming to the safety profile of the study, there are two important features to note down with the addition of tucatinib. One is diarrhea, second one is hepatic side effect, that is rise in AST and ALT. Key feature to note down for the participant here is, it is not bilirubin elevation, because we are combining capecitabine also. Sometimes capecitabine can cause transient bilirubin elevation. So you should not come down on tucatinib dose for rise in bilirubin. So you should monitor for it. What is the median onset of diarrhea in palbociclib? It is quite early, whereas here it is little later in onset. Even hepatitis begins after 1 month in duration. Good thing is, it takes much lesser time for resolution in this situation. And also,
Anderson, sir,
yeah, hi.
sorry to interrupt. As we are exceeding the scheduled time, I kindly request you to conclude at the earlier, sir. Please.
Yeah, sure.
Thank you, sir.
So, yeah, just give me 5 more minutes. So coming to the interpretation of the result, it has shown benefit in terms of adding benefit for addition of tucatinib in this situation, and larger benefit in seen in hormone negative cohort, and CR rate is seen in 9% of population. This is the summary regarding comparison of DESTINY-09, HER2CLIMB-05, and PATINA. Key feature to note down here is CNS progression, not reported in DESTINY-09, which is reported in HER2CLIMB and PATINA, which is showing significant benefit with both tucatinib as well as palbociclib in this situation. And this is very important slide. When we optimize Cleopatra with PATINA kind of regimen, the median progression-free survival is 65 months. With Cleopatra alone, it is 54 months. With TDXD, pertuzumab, it is 48 months. So we have to choose our patient for this kind of regimen. Coming to the future, this is a newer drug, trastuzumab rezetecan, which is about to launch in India by Glenmark. It has shown very good amount of PFS advantage in this situation, which is the future for now. This is with regarding the ESMO as well as NCCN guideline. ESMO already started recommending usage of maintenance pertuzumab trastuzumab in this setting. It is category 1 recommendation. Also for the ER negative patient, they are recommending addition of tucatinib. Again, it is a category 1 recommendation in this situation. Coming to note down here, NCCN recommending paclitaxel also, along with TDXD as a first line setting in this situation. Back to this case, this is our first patient. We started with tucatinib because of the deranged LFT. Even though FDA approved Destiny-09 in December 2025, we took long time because of the toxicity for this situation. Coming to the conclusion, while we have made tremendous improvement in outcome for first-line HER2-positive breast cancer patient, work is still needed to improve the optimizing outcome in this situation. We can consider usage of TDXD along with pertuzumab, especially for patients who are having high volume, high risk diseases, and maintenance kind of approaches like patina or HER2-CLIMB situation. Coming to the future, de-escalation will be the future with either DMETHER or HER2 stop study in this situation. With this, I would like to thank organizer for giving this opportunity. Thank you, everyone.
Thank you, sir, for those valuable and practical insights. And I request to please post your questions in the chat box, and they will be addressed at the end of the session. Moving forward, we are pleased to introduce Dr. Nihanti Srinath, a consultant medical and hemato-oncologist from Sarosh Gupta Cancer Center and Research Institute, Kolkata. Dr. Nihanti will be speaking on sequencing behind first line. Ma'am, we invite you to please take this forward.
Are my slides visible?
No, ma'am.
Is my
Yes,
screen?
ma'am.
Yes, visible. It's visible, Doctor.
Yeah. Prior to begin with, I would like to thank Dr. Tina and the organizers for giving me this opportunity. So without further ado, and with the interest of time, today I'll be discussing regarding how to sequence beyond first line. As Dr. Supreet and Dr. Anbarasan have gone in depth about it, I'll be focusing mainly only on the second line and beyond it, how to progress. So before starting the presentation, we need to ask ourselves a question. Why is it important beyond first line? How many patients do survive in second and third? So we can tell to the audience, maybe it is 1/3 of the patient, that is 30% of the patients of primary don't receive secondary therapy. This is one important note which I would like to emphasize on. And further on, if they go to third line, 34 patients of second line do not receive any third line. So what does this indicate? So currently we are in an era where definitely even after progression with a primary treatment, a lot of patients do still require secondary and tertiary. So maybe approximately 1/3 of the patients we can see in our clinical practice. So we did discuss in depth regarding the Cleopatra, the HER2 climb, everything. So we know the benefit which has happened with the Cleopatra, and now coming to the TDXD era also with the 5-year survival rate which is seen in the metastatic breast cancer scenario. So now why are we concerned about the second line? So why can't we name the second line just to be a palliative or anything? Because most of the patients are in a very good performance status, young age at presentation, and other most important factors to be considered is the disease burden. One is the visceral metastasis which is seen, and that accounts to 47%, and other is the brain metastasis, which may hamper the quality of life corresponding to 25 to 50%. What is this leading to? Poor survival, a late event, and even though there is a good benefit seen, overall outcomes can be further detrimental, with this leading to poor quality of life. So here, if you're further looking into how do we develop the brain metastasis, so this is one of the most major clinical challenge which we face in our practice. Even visceral metastasis, brain metastasis hamper the quality of life. So I won't get in depth of this chart. So where there's an unmet clinical need, that is around 15 to 20% of metastatic breast tumors which overexpress HER2 oncogene have a challenge which exists for these treatment of these patients. So how many of them corresponds to that number leads to 50%? And if there is a CNS progression, again, you need to look into the treatment-free interval, the duration of the last dose which the patient has received, what form of local therapy the patient has received upfront also matters a lot. So with this background, I would like to start my presentation. So currently the NCCN recommendation is definitely we have TDM1, which has been always the backbone based on the Emilia study. Then came the trastuzumab deruxtecan and further on with tucatinib combination, which I'll be explaining further in depth. So prior to the Destiny-03, the main standard of care was TDM1. After the Cleopatra regimen, whenever the patient progressed, we used to give the TDM1, which leaded into the median progression-free survival of 9.6 months benefit. 9.6 months benefit. I'm sorry for that. So what did Emilia establish? Definitely as a second-line standard of care. That changed the entire treatment landscape. And moreover, the benefit was seen was almost 9.6 months. That's from the Catherine data. I won't be getting into the Emilia. I'll be focusing mainly on the Destiny because in the interest of time. So currently the main treatment or whatever has evolved is the trastuzumab deruxtecan. So what benefit? That was almost of median PFS of 19.4 months. So this is a quite significant number if you actually look into any of the second line which you have obtained. So getting in depth of the study, Destiny-03, it was a multicentric phase 3 study. Here, almost 524 patients were included of HER2 positive breast cancer who had received upfront both exposure to trastuzumab and taxane. They had randomized 1:1 and one arm received trastuzumab deruxtecan of 5.4 mg per kg body weight, 21-day cycle, and the other one was TDM1. Primary endpoint was progression-free survival and key secondary were the OS. And further endpoints were definitely the quality of life, the duration of response, and all this were also included. Further on, there was also a subgroup exploratory analysis which shows that how the brain metastasis patients did fare prior to exposure and without exposure also. So I won't get in further about the inclusion criteria. Definitely more than 18 years prior treatment. Exclusion criteria is the patients who had any history of ILD or anything medical history where steroids wouldn't be administered were withheld in this. So coming to the analysis, and if you compare the characteristics of either of the arm, I think the number was quite comparable. Even the patients who had progressed on upfront neoadjuvant treatment were also included, but overall, both the arms were quite comparable characteristics were taken into account. So coming to the PFS by the investigator assessment, the most important thing is looking at the Kaplan-Meier graph which has been present. Yeah, at the early onset, maybe there is a small convergence seen, but gradually the curves are quite well diverged, and even at 60 months, they are quite well separated with a persistent plateau. I think for any oncologist, I think these are the quite well distinguished Kaplan-Meier graphs, which suggests that for a PFS2, that needs to be kept in mind. The PFS2 can be defined as where the PFS1 and PFS which we have obtained by the prior treatment given and the PFS obtained by the current treatment both clubbed together was quite significant, which increase the overall survival. So here the number was 42.7% for TDXD versus 28.1% for TDM1. And the benefit of hazard ratio was 0.55. And if you're looking into the number of months, the numbers almost double. That is 45 months versus 23 months, which was very significant in case of a second line. And moreover, the similar way, the overall survival here, definitely even at 60-month duration, the benefit was quite significant, which was 48.1% versus 36.9. The overall median OS benefit is 56 versus 42 months. I think with an hazard ratio of 0.74 to be considered. So the delta was almost 13 months. I think for any oncological per se, in a second line, there was a clinically meaningful improvement in the overall survival compared to the TDM1, which was given. Now, if any drug is administered, I won't get in depth about the toxicity of TDXD as it was discussed in detail. The common is ILD. I think ILD is the most important thing which needs to be kept into account, and regarding which I'll be discussing how to tackle that also. So the most important features were ILD and rest all were quite tolerable. So what was the conclusion which we can derive from Destiny 03 is, moreover, there was a median PFS benefit which was seen of 29 months in TDXD compared with 7.8 months in the TDM group. And the 5-year PFS rate, which is very important, which is a current updated, shows that 37.6% versus 10% respectively. And if you're further looking into the median OS, definitely the TDXD group fared much better than the TDM1. So these data demonstrate that there is a comparative long-term benefit and efficacy which is seen with the patients who had received TDXD. So if you're further getting into the subgroup analysis, where they did show an explanatory subgroup analysis for the patients with brain metastasis and without brain metastasis. So for the patients who had brain metastasis at baseline, I think if we are further getting in depth of these Kaplan-Meier graphs, there was an improvement of median PFS of 15 months versus 3 months. That's the delta is quite huge with a hazard ratio of 0.25, which is a very well clinically implemented one. And this indicates that definitely even the patients who had received TDXD at baseline did fare better. So on the comparison arm, where the patients without brain mets, sorry for this. Are my slides visible?
No, I think your wallpaper is visible.
Yeah, 1 second, please. Apologies for this. Yeah, is it okay?
Yes, please proceed.
Yeah. I'm so sorry for that. So if you're looking into the patients without brain metastasis at baseline, the patients who had received TDM1, the median PFS was 7.1 months. Whereas if you're comparing the same with TDXD, the main advantage is it's not yet reached. And with the hazard ratio of 0.30, I think these are the very well accepted hazard ratios, which we usually don't see in any clinical practices. I think this indicates that definitely patients who had brain metastasis or without brain metastasis at baseline did fare better with exposure of TDXD compared to the TDM1. So again, here is just a summary for the audience. So there is a benefit seen both in the median PFS, median OS, and further subgroup analysis shows that both the brain metastasis at baseline and without baseline did fare better. And the other important thing is, whenever there is a persistent intracranial disease, how did this subset do? If you're looking into this waterfall plot, definitely the most of the patients had a proper response and a persistent duration of response. I think that is what is very important to take note on. Almost CR was achieved in 10, and even a partial response was seen in 13 out of the 37. So I think this is an again important factor which we need to be considered, that even the overall response rate, the duration of response also were quite significant with TDXD. Now this is a spider plot which shows that whenever the patients have received TDXD versus the TDM1, if you're looking for the response by weeks, I think it's just not only months, even by the weeks, there is a rapid response which has been seen, and I think that's what is the final take needs to be taken on. So the overall, what is the conclusion of the Destiny 03? Patients who had either brain metastasis at baseline, without brain metastasis, even the visceral disease, irrespective of the performance status and exposure to prior treatment line. Second line, I think, yes, compared to the TDM1, TDXD holds good. There is a benefit which is being seen in both the median PFS and the overall survival also. So here I am just quoting regarding the pooled analysis of all the Destiny 01, 02, and 03, especially in the setting of bone metastasis. So if you're looking into the where the Destiny 01, which was a phase 2 data, 02, which indicates a phase 3, which was treated priorly with TDM1, and the Destiny 03 was the patients who had received trastuzumab or taxane, and this was given in the second line. So if you're looking into further comparison of all these pooled analysis, what do they indicate? That yes, even in second and third line, TDXD holds good irrespective of the exposure being given, and this leads to a clinical significant benefit in both corresponding to the PFS2 numbers also. Again, further on, a most important part and the highlight is whenever a patient has both as an intracranial disease, I think this is the treatment of choice currently because of the benefit which is seen with TDXD arm with any of the comparator arm, almost 12.3 months versus 8.7 months, which is noted. Sorry for this. My apologies for this. So thus, what does it indicate is the TDXD demonstrate a trend towards prolonged CNS PFS compared with any of the arms which are seen. Now coming to the Destiny 12, just a brief note, I won't get in detail about it. The patients who had received or with or without baseline or more or less or equal to 2 lines of exposure, how did they fare better? I think all the Destiny trials, the endpoints were the same with PFS and the secondary being the OS and the additional being the quality of survival. The important highlight and the take should be that even in the patients with stable brain metastasis, active brain metastasis, the number was quite comparable, and thus the significant was seen quite well, which shows that there was a consistent 12-month PFS which was seen in both stable and active disease. Again, coming to the overall response also, yes, it is quite significantly mentioned that a benefit of which was seen in either of the populations and further even in the measurable disease also. So what did all the destinies indicated that? Yes, first line already Dr. Anbarasan has mentioned. So second or the third line, the benefit is further seen irrespective of the disease status, let it be visceral or even in case of intracranial. TDXD did fare better than comparative arms, let it be the TDM1 also. So sorry for this. So now coming to the other one, which we are going to discuss today is if a patient has brain metastasis, not eligible or not affordable, because if you're looking into Indian scenario, affordability is another important factor which needs to be taken into account. So what is the other option drug which can be given? Definitely that is tucatinib because of increased blood-brain barrier. The HER2 climb, which says that it was a 2:1 randomization where trastuzumab along with tucatinib versus placebo was given. Primary endpoint was PFS versus secondary was the overall survival, which was taken into consideration. So again, if you're further looking into the Kaplan-Meier graphs, yes, initially there's a mild convergence, but gradually as we go with further on, there's a proper divergence seen and a persistent plateau which is being present currently. I think this is one of the most important take to all the audience is that if a patient is not affordable for TDXD, especially in patients with brain metastasis, patients with tucatinib did fare better compared to the TDM1. I think this is what it's needed with a hazard ratio of 0.34, where the patients have quite significant response. And even currently, we do have a 2-year update also. Patients are still doing quite well. I think this is the one, and even there's a persistent response seen. So what are the side effects of the tucatinib being given? Definitely similar to any of the TKI, the common being diarrhea, nausea, and other hepatotoxicity. But yes, it was quite well administered and manageable. But some important other factors which were seen were also the plumbar plantar erythrodesis, which was noted. So here is a comparison like if a patient comes in a clinical setting, especially in a second line, what to start, either it's a TDXD or a tucatinib. Again, we need to look into the disease burden, the performance status, and also the affordability and cost plays a major role. I think if there is no issues, I think TDXD is still the standard line of management which we would recommend based on the durable delta which is noticed. But in other scenarios, the other options can be tucatinib also and TDM1, which has already been shown a significant benefit. So here we have the pooled analysis of all the Destiny trials. Definitely both with intracranial and the extracranial disease per se, they have done quite better. So how do we sequence for a patient who was presented in our clinic after the exposure? If the patient has not been exposed to trastuzumab deruxtecan upfront, then definitely active brain metastasis, TDXD is the treatment of care. If there is TDXD affordability issues there, then definitely tucatinib and capecitabine is the choice. And even in case of a stable brain metastasis or no brain metastasis, also still TDXD is preferred. The question comes when TDXD is given upfront. That is what is an important thing which we need to know. Maybe currently in clinical practice, I have not used TDXD upfront, but definitely looking into the data, it seems quite significant, especially if it's given in young population and one with brain metastasis. In those scenarios, again, the option comes as either exposure with tucatinib, trastuzumab, capecitabine, or keeping the TRAS2 per 2 in further lines can also be used. We have other data of various other TKIs also, but currently tucatinib has shown a significant care in them. So with this, I would like to conclude my session. Thank you.
For that excellent and insightful session. We now move to the most engaging segment of today's program, a panel discussion on case-based approach. We are honored to have our moderator, Dr. Tina Rajan, along with our esteemed panelists, Dr. R.N. Suprit, Dr. Anbarasan Shekhar, Dr. Ihanti Srihan, and Dr. Shruti Goyal. I now request Dr. Tina Rajan to kindly lead the panel discussion.
Thank you. I'm not able to share my slides. Good evening, one and all. Are my slides visible?
Yes, ma'am.
Yes. So after an elaborate discussion and learning points from our eminent speakers, we move on to a case-based approach to HER2-positive breast cancer, how to implement all these clinical trials into our day-to-day clinical practice. I welcome all panelists. So we'll be moving on to directly onto our first case on early breast cancer. We have a 46-year-old premenopausal lady with clinically T2N1 breast cancer. She is ERPR negative and HER2 3+ with high Ki67, negative for distant mets. So we'll directly start with Dr. Supri. So what is your current practice on neoadjuvant therapy, an ideal candidate for neoadjuvant therapy in HER2 positive disease, and where do you had dual HER2 blockade?
So any patient with T2 disease or more or node positive disease would be my patient for neoadjuvant therapy. And if a patient is for neoadjuvant therapy, she has to receive dual anti-HER2 therapy. There is no second thoughts as of today.
Okay. Dr. Ambarasan, do you go ahead with your TCHP or you add anthracycline? What is your practice and what is the data on omitting anthracycline?
Yeah, hi, Dr. Tina. Currently, we are using anthracycline as a backbone. We have not changed to complete anthracycline-free regimen. Only in those patients who are elderly and not fit to take for anthracycline-based regimen, we are omitting anthracycline. Otherwise, we are going ahead with anthracycline-based regimen only.
Okay. Dr. Shruti, are you here?
Yes, hello, Dr. Tina. Good
Hi, good evening. So now with the Destiny Breast 11 trial, have you started using TDXD into your neoadjuvant setting?
So not yet. The data is definitely exciting, but you know the usual concerns. So far I have not practiced it, but yeah, it's the data is very promising. So yes.
Okay, so our patient has received neoadjuvant dual blockade and now she has underwent surgery and now with residual invasive disease. So what is the importance of residual disease? Supreet, what is your current practice?
So far it's been TDM1, but in this particular patient that you have shown, patient has nodal residual disease. So here my choice would be TDXD. But otherwise, if there is invasive residual disease without nodal residue or there are no other high risk factors that were included in DB05 trial, my choice would be TDM.
So bedside, you decide upon your high risk score, like whether it is nodal positive disease, then you go ahead with the
Or it
TDX.
was inoperable disease to begin with, and now patient has residual disease.
Okay. And what is your ILD surveillance plan? Like if
So,
you're starting on
if
TDXT.
for the patient, we need to see that the patients who were on DB05 had numerically little higher ILD as compared to those who were on TDXT in metastatic settings. So right now there is one patient who is on 3-monthly HRCT surveillance. So far, patient has been doing fine.
Yes, I think we have to be very careful because in the curative setting, when we are using a toxic regimen, so we need to plan very well and avoid any form of harm to the patient. So any role of extended or escalation on your HER2 therapy with any regimens like Compass HER2 or Dr. Amdrasan, are you here?
Yeah, hi Tina.
Mm.
So I think I agree with Supreet kind of management. Now we have to move forward with Destiny 05 and the FDA also approved for Destiny 05. So far I'm not gone with extended Compass or HER2 kind of based design in my practice.
Okay.
Niratinib, I think not a role because it is not available in India and it is quite toxic with the diarrheal rate. And with TDXD coming into the picture, better drug to go for is TDXD.
Okay, I do agree on that. So now we have a very early stage cancer that is a 0.8 centimeter tumor, which is HER2 positive, which is found on screening. So, Dr. Shruti, how will be your approach to this case? Will you de-escalate based on the trials that are available?
Yeah, so definitely because it's a small tumor T1 lesion and node negative, so I would want to go for APT trial kind of regimen. So definitely want to de-escalate here. I would my preference would be this, but attempt also shows very good response with TDM1. But in so far in my practice, I have used APT kind of regimen only, not very commonly used TDM1. So I would offer TDM1 monotherapy to the patients who would want to completely go for chemotherapy-free regimen. So yes, I would want to de-escalate treatment here.
Yeah. So what is the cutoff of the tumor T size you have you use in your clinical practice to de-escalate on the chemo?
So in APT, the cutoff was of 3 centimeter, and but I would want to go for T1 like less than 2 centimeter
2
only. More
centimeter,
than
yes.
that, I would be little apprehensive in de-escalating, especially for the young patients. If patient is elderly, then that gray zone we can give benefit of doubt. But for young fit patients, I would want to keep my cutoff at 2
2
centimeters.
centimeter. Yes, all are comfortable because we don't want to again. So next question is Dr. Supreet, have you started practicing your Fergain or how is the data you're going to?
No, I wanted to mention this while I was presenting itself. We need to remember that all these are still exploratory. None of these Fergain or Daphne, all these are still being established as phase 2 strategies, and they will be expanded going ahead into phase 3. And once we have phase 3 data, I'll be more convinced to use them. So far, no.
Okay. And coming to back to our patient, she had node positive disease at baseline but has achieved a PCR. So do you complete an year of pertuzumab or you avoid it or drop it?
To me, yeah,
Yes.
I would continue. I don't stop. So as I
Yeah.
said, all these are still in their phase 2 and they are not standards yet, but definitely they will be there going ahead maybe in 2-3 years.
Yes. So these were all discussed. So in early disease, we know we are going to a risk adapted treatment escalation as well as de-escalation. So if we have a residual disease, we go ahead with TDXD now and also TDM1 and de-escalation in early stage, very low risk disease. So what we have in the first line is in the early stage diseases, we have antibody drug conjugates that are moving on to the initial phase of management. Now, due to the want of time, we are moving on to the second case. We have have a HER2 positive breast cancer, which was treated 4 years ago, now presenting with massive liver mets and lung metastasis. Rebiopsy showed IHC 3+ and ER weakly positive. Adequate organ function, no CNS symptoms. This is the first presentation of metastatic disease. Dr. Anbarasan, what will be your current practice?
So current practice is going ahead with Cleopatra regimen, especially this patient is having very long DFI. In this situation, Cleopatra has shown very good benefit. And, we need to optimize our treatment line of patient. One size doesn't fit all patient. This moment with the multiple options available in the pipeline, we should screen which is the best modality of treatment for our patient.
Okay. Even if the patient has received trastuzumab and pertuzumab in the first line, because of the longer progression, symptom-free interval or your disease-free interval, you will re-challenge it, right?
Correct. I would go for re-challenge rather than going with the Destiny 9 in this situation.
Okay. Any set of patients, you're going to directly start with TDXD.
So in situations like when I cannot use chemotherapy, like in the discussion, I've discussed one patient with deranged FT, and those patients who are having extensive brain metastasis and skeletal metastasis, in those situations, I often think about going for TDXD. And in the trial setting, they've shown that those patients who are having PIK3CA mutant, in those cohort, TDXD shown much better outcome. TDXD along with pertuzumab. It's not TDXD alone. But so far, I'm more comfortable when chemotherapy is not a very good option or a little bit risky. In those some condition, I'm considering TDXD plus pertuzumab.
Okay. Do you routinely check for PIK3 status in your set of patients, or is it done at baseline or?
So currently, we reduce the cost of our in-house comprehensive gene profiling testing. So for all affordable patients, we are doing at baseline only because of the affordable cost.
Okay. And what would be your choice of your chemo regimen along with the
So our
targeted?
chemo regimen in TMH is primarily paclitaxel. So we majorly use paclitaxel. So we are about to publish our own data of using Cleopatra kind of regimen in our situation. More than 80% of our patients received paclitaxel in this situation.
Okay. Any role of nab-paclitaxel, eribulin, have you used it?
Nab-paclitaxel and eribulin definitely not our choice. We have data for eribulin as a non-inferiority study design, but it has not shown any advantage. Why you want to go for the eribulin when you have a better drug with paclitaxel?
Yeah, if there is any contraindication or you cannot give taxane based therapy.
If it is contraindicated for taxane, eribulin again comes into the same line.
Okay.
Only small difference we observe with the eribulin study is lesser amount of onycholysis, which is seen with eribulin, not seen with paclitaxel. That's it.
Okay. So how will you counsel your patient? Your majority of the patient will be a self-paying patient for Afrin TDXD.
So it all depends on the disease and the other status. We need to discuss all the options available upfront with them. And I will give them whole liberty to choose which is comfortable and convenient for them. Continuing TDXD is a kind of chemotherapy only. Ultimately, whatever the name we put into it, it is a kind of chemotherapy. Continuing it for 3 years, which carries a lot of risk. And TDXD has alopecia risk of close to 50%. So 3 years with the risk of alopecia, also having risk of ILD can happen anytime, which requires continuous regular monitoring. If we missed it out, it will land up with a terrible toxicity. So I will always explain side effects with special interest. What are the key side effects? If the disease demands that kind of aggressive treatment, definitely I go ahead with the treatment.
Just to add, the kind of alopecia that doesn't, where the scalp cooling doesn't work.
No, I have a difference of opinion in this. Scalpelling works in this situation. I have given patients with TDXD with scalpelling. It's definitely okay.
All right.
So Dr. Anbarasan sir has already put us onto this, like pros and cons of TDXD versus THP. And when a patient is having visceral disease with PIK3CA mutation, active brain mets, and a shorter treatment-free interval, and HER2 heterogeneity is again one factor, which we move on to TDXD plus pertuzumab rather than THP. Now, moving on to maintenance therapy, Dr. Shruti, if your patient is on stable disease post your induction therapy, do you put on any maintenance therapy depending upon the hormone status?
So again, yes, Patina has very good data. And it's a very non-toxic kind of regimen, so it's a good idea to actually do that. So I have done it, but not after chemotherapy. So I have patients who are triple positive, who are on anti-HER2 and CDK4/6 inhibitor regimen, but this I have not explored. So this is something which is, but yeah, I agree that it's a good idea to do
Can I
this.
add it up?
Yes. Yes,
So
please.
I have good number of patients who are on maintenance with CDK4/6 inhibitor. One problem I face in the situation is majority of our patient received single agent treatment, not dual anti-HER2 therapy. But even in those patients who received single agent anti-HER2 therapy, when we combine palbociclib, they are showing very good result. Only thing is the dose reduction is essential in majority of our patient. None of my patient tolerated 125 mg for a long period of time. I immediately stepped down to 100 mg or 75 mg. But once the patient tolerates very well, the treatment is going very smoothly. Definitely, you should consider in your patients. The amount of diarrhea episodes reported as such in the trial is not seen in the routine practice.
Okay. And what about adding tucatinib to your maintenance
I
therapy?
have not tried. By and large, the drug recently has shown updated in the guidelines, ESMO guidelines. Previously, it was not there, and it has yet to receive its FDA approval. So I'm yet to try tucatinib in my practice.
Yes.
I
So
have
that's
one patient on tucatinib as maintenance. Patient was, of course, HR negative. If HR positive, I would have used Patina. And it's been 2 months. Patient doesn't have any transaminitis so far. No diarrhea, but we have to wait and see what happens in the future.
yeah. So if we have an HER2 positive disease post for first year induction therapy, if hormone positive, we can definitely add palbociclib to the regimen, maintenance therapy, and if it is hormone receptor negative, tucatinib again has a role. So after an excellent clinical response, she progresses approximately 18 months later. Now she has growing liver mets with no other sites of disease and no new symptoms. So what would be your choice, Dr. Supreet, in this scenario?
Yeah, if the patient is affordable, no second thoughts, TDXT.
Yes. So,
And the patient has received THP in the first line.
yes. So if the patient has not used, if patient has already used TSD in the first line, do you have any option left?
That is a difficult choice, but there is some data to say that TDM1 after TDXT has shown some benefit, or by default it would be tucatinib plus capecitabine plus trastuzumab.
Yes, TTC is a very good regimen. And do you add your endocrine therapy to this if it is an hormone positive disease?
Yes. I strongly believe in adding endocrine therapy, even if it is ER3 or ER4.
Yes. So now the patient has 3 small brain metastases, asymptomatic, which was found on routine imaging. Systemically, the disease is under control. So to Dr. Anbarasan, what would be your treatment choice now in view of the brain disease?
So if the patient is having either active or non-active brain metastasis, TDXD should be considered. It has shown good amount of response rate, close to 70% in this situation. If the patient is not affordable or TDXD used in prior lines, then definitely tucatinib is our choice. But if anyway patient is accessible for newer drugs, there are exciting options coming up in this area. Specifically, there is a zongertinib, one drug which is coming up, zanidatamab, and lot of other TKIs like EZH1401, which is having highest amount of brain penetration among TKI. So if the patient have access, we can consider all those things.
Okay. And what is your opinion on local therapy? Do you use any form of local therapy?
So ESMO has given a clear-cut guidelines. If the patient is having limited brain metastasis, for them, the number of you can go with either SBRT or you can go for resection if it is amenable. More than 10, go with SBRT. I have one experience when the patient is heavily pre-treated, and multiple lesions are there, better go with TDXD, not go with whole brain RT followed by TDXD. Because these patients are no more having poor survival. These patients tend to have good amount of overall survival with more and more options coming into the pipeline. When you give SBRT and then going with TDXD or other drug in this situation, they are having long-term complication like memory loss, Parkinson kind of symptoms. I'm seeing a lot of CNS difficulties when the patient receive TDXD after SBRT. So if it is not clinically appropriate situation, better avoid SBRT in those situations.
Okay. In these set of patients, will you switch your systemic therapy when there is adequate systemic control of the disease and only there is asymptomatic CNS disease?
So switching of therapy or de-escalation is still in trial. It has not come into the practice because if any good drug is controlling the disease, my concern is if I switch into the lesser option, the tendency of progression is much higher. Probably I understand this question is for TDXD. I don't think so. We can de-escalate it. If we de-escalate, what is the next available option in Indian scenario? It's
Okay. And also, my one concern is that patient is on a systemic therapy like THP, like regimen. So if the patient progresses only in the CNS, so
Okay.
would you consider a change in the
That
systemic
situation
therapy?
in terms of oligoprogression, we call it as an oligoprogression.
Yeah, true.
You can add SBRT and then continue with the
Continue your same line of
Both
systemic
antibiotics.
therapy. Yeah. Dr. Shruti, what will be your management of leptomeningeal meds rather than its parenchymal meds? What would be your
It would be same. TDXT would be the choice because it has shown some benefit in leptomeningeal meds also. So it would be the same.
anyone practicing intrathecal therapy?
So we are practicing intrathecal therapy. We give IV intrathecal trastuzumab. I have given for one patient who had a complete quadriplegia, and this patient had access to get TDXD. This was before the launch of TDXD in India. That time, this patient given intrathecal trastuzumab and continued with the TDXD. So a very small number of patients, but yes, we do practice intrathecal trastuzumab also.
How is the response? I have not practically used it. So how is the response to your intrathecal HER2 targeted therapies?
So it is really good, especially before the era of TDXD. It has definitely shown good amount of advantage in our population. We had done a small trial also in this situation for intrathecal trastuzumab, giving 150 mg every 3 weekly. Post TDXD era, I have limited number of experience. Couple of patients only I have tried, but if situation permits, try to go ahead with intrathecal trastuzumab also.
So now we have come to the end of the panel discussion. So we have discussed in early breast as well as in metastatic breast disease. First line therapy in metastatic disease is generally moving upward. Now we have TDXD in the first line along with pertuzumab. And now we have a gap. More have to come in like post TDXD. What next is again a question. And CNS disease again is a primary driver. So it depends upon whether the patient is having a CNS disease or not. So with this, I conclude my panel discussion and I extend my sincere gratitude to all my panelists, Dr. Supri, Dr. Anbarasan, Dr. Shruti, and Dr. Nihanti for their valuable insights, and all delegates have joined. And also I extend my thanks to IAIO for giving us this wonderful opportunity. This was a purely educational session, and I hand it over to the organizers for closing.
Thank you, ma'am, and all our esteemed panelists for such a stimulating and engaging discussion. As we come to the conclusion of today's session, I would like to extend my sincere gratitude to our program director, distinguished faculty members, their expertise and time, and our participants for their activities. We hope this session has provided valuable insights and meaningful takeaways. Thank you once again. Wishing you all a wonderful evening.
I think there is a question in the chat box from Dr. Zamilu regarding how you treat a patient with metastatic breast cancer with brain metastasis as well as triple positive. See, this is a very tricky situation. You need to counsel and give option for both the Destiny 09 as well as Cleopatra followed by Patina kind of regimen. And based on the performance status and other risk factors, you should choose the line for the patient. Obviously, now I go with Cleopatra, optimized Cleopatra, whereas I'm using dual HER2 therapy along with taxane followed by palbociclib will be my first choice. But if the patient is having other high risk features, then my tendency will go towards adding TDXD in the upfront setting only. Thank you.
Thank you, Dr. Anbarasan, for taking that question.
Yeah, thank you, Tina. Thank you, organizer, for giving me this opportunity. Thank you.
Thank you, Dr. Tina. Thank you, organizers, for giving this opportunity. Good night.